So, good afternoon. I'm very glad to introduce you to this seminar focused on E-CPR on behalf of the KnowEMS Consortium. It is the fourth webinar organized under the umbrella of this European project. The aim is to highlight key home messages on specific topics dedicated to EMS and to share knowledge and protocols between us, following what we did during the KnowFair project. I am sure that you wish to know more about our KnowEMS project, and I will pass the floor to Lisa.
Thanks a lot. I will only need a minute to add a few information to what Catherine just said. Thank you, first of all, to be here. On behalf of the consortium, I would like just to briefly introduce the KnowEMS project for all individuals that are joining our webinar for the first time today. KnowEMS is the short form of Knowledge Network of Workable Emergency Medical Systems. And we started this project, which is co-funded by the EU, in January this year, and in total it will run until December 2025. The consortium behind this project consists out of 7 organizations representing 6 different countries. And here we have Joanita from Germany, we have Magan David Adom from Israel, Inem from Portugal, DSU from Romania, Ayuntamiento de Madrid from Spain, SFMC from France, and also Assistance Publique Hôpital de Paris, also from France. As mentioned by Catherine, KnowEMS builds up on a further project called KnowFear. It has been identified that there's nearly no network existing for EMS to exchange knowledge on a national level. This was a serious issue during COVID. As you probably remember, the pandemic has had a different level in various countries at the same time. So here we are with KnowEMS. And what we are doing now, among other things, is in the frame of KnowEMS, we set up monthly webinars where we are discussing hot topics for EMS staff to give them the opportunity to learn from each other. And therefore, we invite presenters from organizations and authorities all over Europe and beyond to talk about very specific experience and their lessons learned. The webinars are scheduled for the first Thursday of each month, except the coming webinar. This will take place exceptionally on Tuesday, the 1st of October, but more about it at the end. Last but not least, we have a network behind it. So if you would like to participate in the in this network, please join us. You can find us on social media and on our Knowledge Network website, but I will show it in the end again. And for those of you who would like to receive a certificate of attendance, this is important. Please stay with us. At the end, we will share a QR code as well as a link where you can register yourself to receive one. One more information, the meeting will be recorded and uploaded on our YouTube channel. That's it. Back to you, Catherine.
Okay.
Catherine, if I may, Lisa, can you share a link for people who cannot connect? I understand that some people have issues.
I will do
connecting.
so.
Thank you.
I will put it in the link.
Thank you.
Okay, so today we have 3 presentations. The first one set in the French pre-hospital setting by Dr. Alice Hutin. Second one, E-CPR in the field by our colleagues from Israel. And the third one, how teamwork between pre-hospital and in-hospital staff, how it improves E-CPR outcomes. So it will be by our colleagues from Spain. May I introduce Dr. Alice Hutin? She is an emergency practitioner at Saint-Louis de Paris and a key resource in E-CPR research and practical use. Of course, ECPR practice relies on our French pre-hospital organization we talked about previously in the first webinar. Not to mention that all webinars are collected on YouTube, as Lisa told you. Dr. Alice, their friend, I pass you the floor.
Thank you, Catherine, for the invitation and your kind presentation. I will try to share my screen again. Is everything okay? Can you see my screen?
Not yet. It's okay, Alice.
Okay. So yeah, thank you again for the invitation. My name is Alice Hutin. I'm sorry?
No, sorry, I was answering Eric. He cannot find the link. Sorry.
Okay. So I'm a pre-hospital emergency physician at the SAMU de Paris in France. And I will talk to you about our ECPR program. So just a little bit of an update. I guess you are all ECPR enthusiasts if you're here, but basically ECPR has been incorporated into the latest AHA guidelines on cardiac arrest as a treatment to consider for selected patients when it can be appropriately set up. So definitely it's something that you need to think about. And these are some of the questions that we try to answer on a daily basis in the sense that ECPR is not for all out-of-hospital cardiac arrest patients. So we need to select these patients and make sure that we treat them within the right time and in the right place, as we will see. So basically, for who is ECPR, the main thing is that we want to select patients who have hope for neurologically intact survival. And beyond all the rhythms that you might encounter, the suspected causes, what you need for these patients is an optimal chain of survival. And this starts from the call to the emergency medical service with the early recognition of cardiac arrest and the fact that you need to have patients undergoing CPR with bystander CPR, sometimes if you have access to community response, of course, that will help. And then make sure that BLS and ALS teams are on their way. And if you have this optimal chain of survival, in some cases, you do not have ROS, and you need to be able to answer the question early, is the patient eligible to ECPR? And if yes, you want to be able to deliver ECPR within the right time. This timing, we actually have quite a bit of data on this now, and we know that the patients who survive, who benefit from ECPR, are those who are treated early. And what we mean by early is optimally within 60 minutes of cardiac arrest. And as studies are being published, we realize that 60 minutes is really the maximum cutoff that you want to aim for. Of course, there are survivors beyond, but 60 minutes is what you want to aim for. And we see that patients who are treated beyond this 60-minute cutoff actually have less complications and usually better prognosis. So you really need to have this in mind when you try to organize your system. And so when you have this in mind, you need to know where you're going to be delivering this ECPR. And basically, the place where you will be treating the patient with ECPR is the place where you can have the patient under ECPR within 60 minutes. So in some places, it will be in hospital. In others, it might be pre-hospital if you are able to do so. Obviously, for those of you, and many of you who are part of the pre-hospital EMS, you know that everything takes much more time than you expect. And these are a few pictures of Paris, and you can see that taking a patient outside one of these high-rise buildings is very complicated. And then when you get to traffic, which is obviously very often like this, like you can see here in this picture, transfer times are much longer than you estimate. And then when you keep in mind that you need time in the hospital to cannulate the patient, if you add up all these times, you can see here that we are very easily beyond these 60 minutes that we aim for. So this is really where the idea of pre-hospital ECPR came from, in the sense that if we can try to get rid of at least this transfer time to the hospital, we can try to bring the low flow duration down. And with this, we try to increase the probability of survival for the patients that we are treating. And this is how we try to organize our dispatch system, in the sense that when we have a call for a suspected witness out of hospital cardiac arrest to the SAMU dispatch center, we actually have the simultaneous dispatch of the community response, the BLS team, the mobile ICU, which is our ALS team with a physician on board, and the ECPR team. With this, we are able to have the ECPR team on the scene early to be able to decide early if the patient is eligible to ECPR or not, and then start with the cannulation on the scene. All of this, again, with the hope to have the patient, or with the objective to have the patient under ECPR within 60 minutes of the cardiac arrest. This is a little bit of how things are organized in Paris. You can see here that we have a dedicated vehicle, a multidisciplinary team of 3 people, and I will be presenting this in a little bit. And everything is very anticipated. You can see here that we have all the equipment that we need to deliver CPR, conventional CPR, and then what we need to move to ECPR with the device here that you can't really see, the Lucas device to deliver mechanical CPR. And everything is checked on a daily basis to make sure that when we are on the scene, we have everything and nothing is left to questions in the field. This is an example of a cannulation in place where we had a lot of space. You can see here that there are a lot of people, but everything, although it might not look so, is very organized, and people are trained. They know where they can be and how things are organized when we are actually going on to ECPR. Basically, in the team, we have a physician, an anesthetic nurse, and a paramedic. The physician is the person responsible for taking the decision of going of treating the patient with ECPR. The decision is obviously taken with the mobile ICU physician and the teams, depending on all the circumstances and all the chain of survival I mentioned earlier. So the physician also does the cannulation, and basically, once the decision is taken to go on to ECPR, the ECPR physician is more or less a person who overviews the whole scene. The anesthetic nurse is a person responsible for preparing the machine. We've moved to having pre-primed machines to bring the low flow down again and make sure everything is as fast as possible. And the idea is that the nurse makes sure the machine is available, ready, and connected to the oxygen mixer, because unfortunately we won't have time to talk about post-cardiac arrest care, but we really do not want these patients to have too high PaO2, so we have an oxygen mixer to avoid that. The idea is also that we want to monitor these patients as much as possible, and once the patient is under ECPR, we have an ART line put in, and this is the anesthetic nurse who is responsible for this, to make sure that we can titrate vasopressors in the right way and monitor the patient as much as possible, because although we are on the scene, we want to start post-cardiac arrest care as early as possible. The paramedic is the person, first of all, who gets us to the scene, and in an emergency setting, it's really something, a big responsibility, I would say. And the paramedic is responsible for getting the equipment ready for the implementation, and all the equipment, is given to the physician in sterile conditions, as you can see here. Once the patient has been implemented with ECPR, the paramedic is also responsible for trying to deal with the whole scene, wrap up, and make sure that everything is cleared when we leave the scene. You can see here we tried to compare two different periods of ECPR implementation. In the first period, the dispatch of ECPR was done after mobile ICU called back the EMS, confirming that the patient was potentially an ECPR candidate. But we found that we were losing time. So in the second period, we decided to dispatch the ECPR team at the time of cardiac arrest, as I showed to you earlier. Globally, we can see here that if we add an aggressive management of dispatch to pre-hospital ECPR, we are really able to bring down the low flow time and try to aim for the 60 minutes that I mentioned earlier. These are a few examples of pre-hospital ECPR implementations that you might have seen who were published a few years ago. These are more or less the situations I have been in. And obviously, I showed you earlier a picture outside. Most of the time, we are actually in apartments or in settings that are not very friendly. And it's really important in those times to be very organized and anticipate every step of the way, because the scene can be quite hostile in some cases. Just to explain as well, that the idea is really to make ECPR available to as many people as possible, and not to restrict this treatment to patients who are in a certain geographical region. For example, for us, not to restrict ECPR to Paris only. So we are able to dispatch our ECPR team on a heliborne manner. So if we get a call for patients outside the city of Paris, very far away, we are able to take the helicopter, load the helicopter with all the equipment that we need. And you can see here that in these situations, with further distance, obviously the low flow time is much longer, but we still have survivors. And we will, again, not have much time to talk about this, but organ donation is also a subject that we will be talking about more and more in the decades to come concerning ECPR and potential benefits of ECPR. So pre-hospital ECPR is definitely a solution in some places. In other places, in-hospital ECPR works. And there's a new idea that is progressing these past years. Is the idea of doing a sort of rendezvous, in the sense that the ECPR team meets the ALS team in the middle, not on the scene, but it can be in a hospital where there is no in-hospital ECPR, but the pre-hospital ECPR team is dispatched there, so that the both come together and try to bring the low flow down again as much as possible. These are some of the settings in which pre-hospital ECPR is being delivered now. You will obviously hear about other cases, other places as well in this webinar. But definitely, it will be interesting in the years to come to compare these systems and see if pre-hospital ECPR is really beneficial for the patients we are treating. So the idea is really with pre-hospital ECPR to get these patients on pump as early as possible, and as I mentioned earlier, to start post-cardiac, post-ECPR care as early as possible on the way to the hospital. Just to conclude, the idea is really that you need to anticipate your system. ECPR is now recommended for refractory cardiac arrest patients, so you need to anticipate your system and see how it can work on a local basis. The idea is really not to say in-hospital is better, pre-hospital ECPR is better, but you need to make things work where in your system where you are working, and to make sure that all the people taking care of the chain of survival are on board and working together. So once again, you need to anticipate your system for refractory cardiac arrest, aim for an optimal chain of survival, because ECPR will only be efficient if the patient is treated with bystander CPR and an optimal link the whole way. Obviously, you do need to select patients, and if we have time for questions, I can answer these aspects as well. Optimal timing is definitely a major aspect, but really keep in mind that ECPR is a whole bundle of care that relies on multidisciplinary care, and you need to train with all the people who will be taking care of these patients on the scene. Thank you very much, and if you are interested in ECPR, we have a course in Paris. You can find the information here. Thank you very much.
Thank you very much, Alice. I have just one question. When did you start this practice?
Well, it started 10 years ago in 2011, the very first cases.
So I'm
here.
Oh, okay, Thomas, so go ahead.
Yeah, sorry, I had some issues, but I hope now everything is okay. So hi, everyone. My name is
Thomas. Do you
Tomer.
want me to stop sharing the screen and you will share from your computer?
Perfect.
No more screen.
The floor is yours. And until Tomer is sharing his screen, just want to say that I'm honored to be here together with Alice. We were part of the group that we were in her course in Paris.
I remember, thanks.
Shafir, maybe you share your screen if Tomer has having issues and he just asks you to move the slides.
No problem.
Tomer, I suggest you start speaking and.
Okay, but I can't see the screen. But once it will be on.
Are you given the course in English?
Yes, yes, in English.
Good.
Yes, it's all in English, yeah, with the speakers from around the world. Yeah.
Very good.
Okay, so hi everyone. Sorry for the short delay. As I was starting to say, my name is Tomer Kaplan. I'm the head of the Quality Assurance and Patient Safety Department in MDA. I'm going to present a short presentation of our experience with the pre-hospital ECPR. So first of all, when we started approaching the issue, we looked on what we know that's going on in the world on the out-of-hospital cardiac arrest in general. So what we know from the literature is that the survival rates are somewhere between, when I'm saying survival rate, I'm talking about CPC 102 with good neurological function. So they're somewhere between 2 to 9%. Even in the Western world, that's around the percent of the survival in those countries. Of course, that there are some countries that have higher percents and they measure differently, so the variability is quite large. And the average ROSC rate is around 30%-ish. But as I was saying, the inclusion and mainly the inclusion and exclusion criteria impact the rates within countries that have modernized EMS systems. Shafir, you can go on. And pretty much everybody agree about the survival definition of the patient. We're talking about general survival and survival with a good ranking score. So when we were looking in Israel, the first big high quality research that was done in the country was done in the years 2005 to 2010 by Professor Sharon Einav. It was done in the city of Jerusalem. But at the end of the day, MDA is MDA wherever you go. So even when looking in Jerusalem, we can say maybe it's a reflection to the rest of the country. And what they found in this research is that the overall survival rates was 6.1%, and survival with good ranking score was 3.4%. We started thinking again on maybe the statistic have changed after around 10 years, and we said, okay, now we know that our dispatchers know how to guide CPR better or identify CPR better. Also, which was also correct for the teams on the ground. And we know that we started distributing, it was pretty much the beginning of the mass distribution of defibrillators in the public spaces, public environment. And also we have the life guardians, we have on-call first responders, and also an app for the general public that if you have any medical training, you can register to the app, and then it identified people within the environment of the event, and it gives them automatic call. So we said, after all of those advantages, let's see how much we improved. And what we found was it was okay, not very good. We found that the overall survival and the survival with good CPC raised in an average within 1%, which is not a little, but for us it wasn't enough. And then, שפיר, אפשר להמשיך? And then we said, okay, so maybe we can make things better, and we looked on system that we know that works better. Everybody knows Kings County in Seattle and some other European systems, and we said, okay, maybe we need to see how we make things better in-house. So we took several steps to see what we can do. השקף הבא. So first of all, we know that in order to improve, you have to measure yourself properly. And until now, there weren't a good measurement system or still there isn't a good measurement system within Israel. There is no out-of-hospital cardiac arrest national registry. So we had to invent one. Since the Ministry of Health doesn't run one, we made an electronic registry that actually goes over. Now, what we did, that every time that the EMS personnel, when he fills up the patient forms, put a code for cardiac arrest, an automatic window will jump, and then he'll have to fill up certain fields, mainly the Hutin criteria, but some others, certain fields regarding CPR. And then we have a digital registry, which is collected very soon after the event, and it's quite a reliable data source. It's not the most reliable, but it's better than what we have before. Another thing we do is we said, okay, up till now, every personnel in the EMS nowadays know how to recognize gasping, know what's the key factors of proper CPR, but we need to find a way to do it better. So even when you know it, you still have to train on it, and we have to put focus on the main issues that actually harm the patient during CPR. And everybody knows that not enough recoil, not deep enough compressions, and when you ventilate the patient with high pressure, you're not helping them survive. So we took training courses to the teams on the ground and to the dispatch centers, to every call taker. We enlarged the AED coverage even more, and now we have a very good spread across the country, and we also mapped all the existing AEDs in the country to our command and control system. So every year we have a defibrillator day in Israel that MDA runs, and we invite people to register their devices with an app. They just go next to the device, send a GPS location, and then the device shows up on our command and control center. On the side of the dispatcher tools, so now they can see the location of the caller. They can video chat with the caller and give them proper, first of all, identify that it is a real cardiac arrest and give them proper guidings. We have a timer that starts once they selected the code of cardiac arrest in the dispatcher side. Timer starts to run in order to make them continue and start guiding CPR very fast. And we have smart cabinets of the defibrillators that the dispatcher can open across the country, all over the country, that the dispatcher can open from remote, from the dispatcher side. He can open the cabinet, and then there's an alarm that goes on. So the caller can easily find the device on the street. Another thing we do is the implementation of new techniques. So only this year we implemented the DS, the double sequential external defibrillation, and the vector change, following the big research that was published in the New England in November 2022, which measure those techniques. For those of you who are not familiar with the techniques, the DSCD, what it does is you give, after the regular method of treating a patient in refractory VF didn't work for three rounds. On the fourth round, we added another device in a posterior anterior position and another set of pads, and then you give defibrillation from two devices almost at the same time, 0.12 seconds variance between them or more. And the vector change is just switching the pads from the sternum and apex to anterior posterior location. It was a big research that was done in Canada with 6 big EMS organizations. And what they did is that they did two organizations at the same time, did different methodology for treating refractory VF. And after half a year, they changed the way they treat between the two organizations to the next two organizations. And at the end of the day, they collected the data with a large data, a lot of patients, and they found that the survival rates was, I think it was 11% for the conventional mode, meaning in a refractory VF, if you continue using the sternum apex method for the following shocks, for the following defibrillation, 11% survival. For the vector change, it raised to 16% survival, and for the double sequential external defibrillation, it rose to 27% survival. And following that data, it's also now part of the American Heart Guidelines, and we had to adapt it. So it's another thing that we implemented. And at the end of the day was the ECPR, which was also something that we said, okay, if we can, any added value we can give to our patient is something that we're going to look on. And then we started looking on the ECPR. Yes?
3 minutes.
Okay.
You're already over time.
So skip the research and תדלג שפיר לשקף הבא. דלג גם על זה.
I will switch to our result.
דלג.
We have still 20 minutes of time.
Sorry?
לחזור?
Okay, so the research data that I wanted to show as the background is something that I heard before, so I know everybody already are familiar with it. But at the end of the day, what we found was that the fact that now we know that the sooner you connect the ECMO device to the patient is better. It's better to do it in a sterile environment, but if it's a sterile environment versus additional time, then we prefer to do it on scene. שפיר, קח שקף אחורה רגע. עוד אחד.
It starts here, about Israel.
סבבה טוב, סבבה. כאן. So, דילגת, לא?
No.
Okay, so what we did is we measured we did it with one hospital, one big hospital in the center of Israel. What we did is we took a range of 20 minutes arrival time, and then we created guidelines for the dispatch on which calls are the ones that we send the ECMO on, which is the criteria pretty much everybody use, up to 65, no known serious comorbidities, that it was a witness arrest or an arrest that happened within the last 5 minutes, that somebody is doing CPR on the ground, and then we do simultaneously and the regular ambulance, not ambulance, an intensive care unit and the ECMO unit are dispatched to the event. We're starting doing the CPR. The EMS teams are in charge of the upper body, meaning they're doing the CPR, they're connecting an automatic mechanical compression device, and they stop giving adrenaline, and they'll stop doing shocks while the cannulization is happening. And then the ECMO team is taking the lower part of the body, make the sterile environment, and does the connection of the patient. What we learned so far. So first of all, a good dispatch or a proper dispatch and good communication with the field is key. Our average time, we didn't have a lot of connections so far, but our average connection ECMO on time from arrest is 38 minutes at the moment. We are still in the dilemma of which criteria we want to use, because following the criteria I just mentioned, at the end of the day, when the dispatcher get a call of a 70-year-old person that collapsed and it was a witness collapse and somebody starts CPR, we're still launching the ECMO unit and they're still connecting this patient. So we want to stay human and we want to give everyone a chance. But at the end of the day, when you want to present results to the decision makers and the Ministry of Health, if you don't stick to the strict criteria, your results will be not as good as you could present them if you would stick to the criteria. But we're paying this price and we're going on the human approach at the moment. We understood that we need to enlarge the coverage area. So what we're going to do next is a rotating unit, ECMO unit that will move between the hospitals within the center of the country, and then maybe we can reach more events. And I think the main thing is that it's not, I'm thinking now that for every region, an hybrid approach is probably preferred, meaning if the event is 5 minutes from the hospital, I would probably prefer to take him during CPR and do the cannulization in a sterile environment. And if the time we can cut off more time, then maybe a mobile unit would be better. שפיר, אתה יכול להתקדם.
Tomer, which you wanted to present our numbers for the end?
זה בשקף הבא, לא?
No, it was.
Okay,
No.
so yeah, so our numbers so far, as I said, and the small asterisk on top is there because at the moment we're only working morning shift, and as you know, we had some some issues for us to keep the operation working regularly within the situation in Israel at the last year or so. But
Tomer, 1 minute.
So far in 21 events, we had boots on the ground, meaning the ECMO team arrived to the CPR, to the out of hospital cardiac arrest. We did 15 cannulization attempts. From those 15, 11 were successful. 30-day survival, we had 6 patients, and survival with CPC 1 or 2, we have 4 patients. This is our number so far. It's just the beginning. And we hope for better numbers and more people going back to their houses at the end of the day. I think this is it.
Okay, thank you very much.
If you want,
I think that it's time to pass the floor to our colleagues from Spain. You have 15 minutes or maybe 14 minutes.
Sandra, are you there?
Nothing on the screen yet.
And the mic is off.
Yes, right.
Can you see the presentation now?
Not yet.
No, Sandra.
Okay.
No.
Because it says we are sharing it already here.
Okay, would it help if I share my screen with your presentation and you just let me know when I should skip or switch? Okay, perfect. Can you see it?
Okay, it's okay.
Great. Please, Sandra, go ahead.
Okay, so well, thank you very much for the invitation. For us, these kind of experiences are very important because we grow as a team and we are able to improve the results of our patient, which is our main goal. And
can you speak up a little bit? Yes, okay.
Yes?
It's okay.
Now? Okay. So without any further delay, I would like to share the results of our experience in Madrid in Hospital Universitario La Paz, of course in collaboration with SAMU Protección Civil. I'm not able to see the presentation that you're sharing, sorry. Lisa?
Yes, so you can't see it, and I will share it again. Sorry for that. Can you see it now?
That's okay.
Okay, great.
Okay, now. So can we change the slide, please? Next. Okay, so as we know, almost 20-30% of out-of-hospital cardiac arrest patients have initial shockable rhythms, and that initial shockable rhythms are responsible, or almost 60% of survivors with good neurological outcomes. Unfortunately, next please, almost half of the patients will develop a refractory ventricular fibrillations. And next, Now we know that these patients, until some years ago, if we were not able to achieve a sustained return of spontaneous circulation over a period of over 30-40 minutes, these patients will have a probability of survival with neurological outcome of CPC-1-2 very low, under 1%. But now ECPR has emerged and has opened a new window of opportunity to these patients. Next, please. The question today in 2024, as my previous colleague says, is really ECPR for everyone, and can it be performed in every center? Well, I'm a specialist in acute cardiac care and I love ECMO, but my answer is right now definitely no. By now we have already the results of 3 well-performed and well-designed randomized control trial, the ARREST, the PRAGUE, OCA, and INCEPTION, and we have learned very valuable lessons from these randomized trials. Next, please. Here we can see, next please, the ARREST and the PRAGUE, OCA trials took place in centers that had a lot of experience with ECPR, some of them more than 10 years of experience. And these centers, the study intervention included not only ECPR, but also early revascularization and the performance of an immediate coronary angiography. On the other hand, the INCEPTION trial was a trial that took place in a developed country with a lot of resources, the Netherlands, but the hospitals that performed ECPR didn't have, not all of them had the same experience with ECPR. Another difference between the trial was that the ARREST trial focused on initial shockable rhythms, and as well as the INCEPTION trial, while the PRAGUE OCA could have all the rhythms included, while the etiology was presumed to be cardiac. Next, please. Next. So which are the results? We can see here from the ARREST trial that the differences in survival were very significant at discharge at 3 months and for 6 months in the ECMO arm. And they also showed us, next, that the patients, even if they went home with a CPC of 3, they had a chance of recovering in the next 6 months until they got a CPC 1-2. Next. The PRAGUE OCA also found differences of survival in the first 30 days. These differences were lost along the time during the first 6 months. Next. This difference might be lost because there was a very high rate of crossover. Actually, 4 of 6 survivors in the standard arms received ECMO. Next, please. And now they have published their 5-year results, and they are very nice. They show us that the difference for survival with good neurological outcome are better for the ECPR arm. Next. And next. In the 3 statistical analyses. Next. And also they confirm that the patients, even if they go out of the hospital with a CPC higher than 2, they can recover to a CPC 1 or 2 during the first 6 months. Next. So then the INCEPTION trial came, and we saw here that we didn't have any differences between ECPR and conventional maneuvers. Next. One of the main reasons is that they didn't have the same experience with ECPR. We can see here that the cannulation and the low flow times were higher compared to the previous studies. Next. And now we have a lot of information that shows us that if we are able to be fast in the cannulation of ECMO, we can improve the survivals of our patients. So this is very important. Next. But not only cannulation, also the case volume of ECPR on each hospital improves the survival of the patients. For each additional 10 cases of ECPR, patients can survive better. Next. And we can see here in the INCEPTION trial that half of the centers were low volume centers, less than 10 cases per year. One hospital had only 1 center. Next. And the patient could come into the cath lab or into the ED, into the emergency department. And we know that refractory patients have in almost 85% significant coronary artery lesions, and that 65% will be acute coronary lesions, acute coronary syndrome. So it is very important, next, to bring them into the ER, into the cath lab directly, because this coronary disease usually affects many arteries, and mainly the left, the LAD, the left arterial descendant. Next. So catheterism improves the prognosis of these patients. Next. Especially when they have an acute coronary syndrome, and especially when we can perform a complete revascularization. Next. So what do we believe are the keys to success or to obtain results with ECPR? Well, of course, the foundation of ECPR, as my colleagues already said, is the teamwork. We have been working with the SAMWE for some years now. And next, please. We know that in order to improve results, we have to take quick decisions, quick and joint decisions between pre-hospital and in-hospital services in order to reduce low flow times. Next. In our case, SAMWE team is responsible of identifying eligible patients, and when they identify a refractory arrest, next, they go through the established criteria. We established commonly the criteria, and they resemble a lot those suggested by the ELSO. There are small differences. Next, we are still asking for patients younger than 65 years because we haven't had any survivor over 68 years. Next. And we are only working with initial shockable rhythms because we are specialized in cardiology. We're an acute cardiac care unit, so we don't take patients without initial rhythms. Next. So when these criteria are confirmed and the cardiac arrest is non-traumatic, next, the SAMWE makes a phone call directly to the hospital and tries to arrive in the first 45 minutes. Next. When they make the call, next, the call is received by a specific ECMO team that works 24/7 in the hospital. This ECMO team is comprised by 17 specialists, only talking about the doctors. We are 17 specialists comprising acute cardiac care, advanced heart failure, complex congenital heart diseases, next, and of course, interventional cardiology. Next, this team will of course go again through the selection criteria because we know that sometimes in field the information is still not clear or there are some things that should have been cleared before, so we go again through the selection criteria. Next, and we prepare the cath lab where we believe next the patient should be received. Next, please. And this is a picture of the cath lab. No, the previous one. This is a picture of the cath lab where we can see all the resources that we need in the hospital to receive a patient like this. But I would like to make a remark on the human resources. We have 2 expert nurses on field, 2 acute care cardiologists on field, and 2 interventional cardiologists with experience in ECMO, in fast cannulation of ECMO. Next. So when the patient arrives to the hospital, our first fight is against time because usually we have less than 15 minutes to put ECMO in. Next. And here are our times. When we began in 2020, we had higher times and we have improved a lot over times. Actually, last year we had a mean time of cannulation of 10 minutes and some patients were cannulated in 6 minutes. 2024, these statistics only include patients until August the 1st. And our majority of patients come through autumn and winter, so we are still missing a large proportion of patients. So we are more above the range of the studies with good survival. Next, please. And we know that not only reducing the time is important, but that also to improve results in ECMO, we need to reduce the complications in the cannula access site. So what have we done to reduce traumatic bleeding and ischemic complications? Next. Well, we have chosen a bilateral femoral cannulation, echo or micropuncture guided. Up till now, we have a 0% failure in cannulation. Next. We use a small size ECMO, 15 French in the arteria to simplify the things. Next. Next, please. And initially, we do not put in a distal perfusion cannula to reduce the times. Then we have to keep on watching the patient's irrigation of the leg, and we can put it afterwards in the ACCU. Next. And we don't place the distal cannula, and we don't have a lot of ischemic complications. We can see here on 2023, we only have 1 complication, and this complication requires surgery, but it was not actually during the implant of the ECMO, it was during the withdrawal when we failed to place a percutaneous device for closure of the arterial cannula. And in 2024, we had a leg that had ischemia, but this ischemia was corrected with the placement of a distal perfusion in the ACCU. Next. After the ECMO is in place, we perform immediately a coronary angiography. And if we don't have any significant finding and we believe that the cause is still cardiac, we can also perform a pulmonary angiography and mechanical thrombectomy when necessary. We are working also if the suspected cause is a pulmonary myocarditis in trying to get the biopsy early, as we have results from recent publications. Next, please. And also, unloading of the ventricle is very important for ECMO results. So we perform an echocardiogram always before leaving the cath lab. And if the patient needs an intra-aortic balloon pump, we put it in place in the cath lab, or we make a close monitoring in the ACCU during the first 6 to 20 hours. More than 50% of the patients require an intra-aortic balloon pump for an adequate unloading of the ventricle. Next, please. And finally, to improve all the outcomes on the ICU, we also have to overcome a lot of challenges. Next, please. First of all, when the patient arrives, we always go through an ECMO safety list. This seems to be irrelevant, but actually it can have a great impact on the prognosis of the patients. Next, please. Here we can see in this slide that the devices on running, the problems on running the mechanical devices influence or alter the good prognosis on the survivors. Next, please. And also we put a BIS monitoring on each patient so that we can do an individual dosing of sedatives. This has helped us to reduce the complications, to reduce the days on mechanical ventilation. And with this strategy, we make a lesser delay on the process of neurological prognostication. Next. Regarding TTM, we know that we are still missing a lot of information on whether if ECPR patients should be on TTM or not, but a lot of groups are still doing it in hospital, and usually at 34 degrees. We are using still 32 degrees because we believe these are the most complex patients with a lot or a very high inflammatory response. Next. And we know that patients on ECPR that go through TTM have significantly better neurological outcomes, so that's why we still do TTM. Next. Also, as I told you, we are very specialized in cardiac patients, so most of our patients have an acute coronary syndrome. So although they have a high risk of bleeding complications, we also have to do a good management of antithrombotic therapies. And we know that these patients, if they undergo a wrong treatment with clopidogrel, they have a high rate of stent thrombosis, over 30% of the patients. So we should always prefer prasugrel and ticagrelor. And next, please, if we are not able to give prasugrel or ticagrelor, we also have experience with intravenous cangrelor, which we know it's safe and it doesn't have a drug interaction with ticagrelor. And up till now, we have a rate of 0% of stent thrombosis in these patients. Next, please. Also, infectious complications are very important. We know that over 40% of the patients experience pneumonia. Most of the patients have an early onset pneumonia. That's why we have cultures at admission and upon clinical suspicion of all the patients. Next. We use a lot of antibiotics in our patients. We can see here that almost 90% of the patients have antibiotics in the first days of in-hospital admission. Next, please. Next. The most common antibiotics is amoxicillin clavulanate in more than 50% of the patients, followed by piperacillin tazobactam. Next. And we have learned that patients that receive antibiotics early in the course of in-hospital admissions have less frequently late onset pneumonia. Next. Finally, when patients finish TTM, we start to perform a multimodal neurological prognostication. We do a clinical evaluation. We perform at least 2 EEGs, except if the situation is very clear, the patient is awake, or he or she has signs of brain death. And then we also have serial neuron-specific analyzed levels, because we know that they help us identify the patients that will have a CPC 1 or 2. Next.
Sandra, you should conclude.
Yes. We never perform withdrawal of life-supporting therapies in the first 72 hours because we know they are late awakeners, almost 30%, especially if patients were under 33 degrees. Next, please. And then our results finally, next. With this common work, on 2023, we had over 50% of survival of the patients with CPC1-2 of out-of-hospital cardiac arrest patients. In 2024, we're still missing a large pool of data, but we are around 33%. And we have also improved our organ donations, almost 50% in this year. Next. So we are at the level of the centers that have been performing ECPR for a lot of years, and this is a result of a lot of effort between the pre-hospital and in-hospital systems. Next. Thank you very much. I'm sorry, because it was very difficult.
No, it's okay, Sandra. Very interesting.
Not having the control. Sorry.
So thank you very much, Alice, Tomer, and Sandra. So I think we are going to switch to the expert time.
Yes, but before that, you have the QR code for the certificate of attendance in front of you. So please scan it if you want a certificate of attendance.
Not really. This one is the QR code you can scan to follow us if you would like to become a part of our network. You will also find the link and a QR code in the chat. It has been posted already, and it will be open until Wednesday next week. After that, we will upload the video. Also, please join us on our webpage in the EU Knowledge Network. Also join us on YouTube if you would like to see the previous webinars. And we are also present on LinkedIn.
And please join us on October 1st for a webinar dedicated to EMS in conflict situations, where we will be presenting the experience of the EMS in Ukraine and of Magen David Adom in Israel in the attacks of October 7th last year.
Thank you very much for being here.
Yeah, thank you very much for attending.